I would love to introduce our esteemed moderator, Dr. Folake Olayinka. Folake Olayinka, who is a global health expert and immunization expert, most recently leading immunization technical activities with USAID. We're thrilled to have you moderate our session, and we turn things over to you.
Chantal, thank you very much, and a warm welcome to everyone today. I am pleased to welcome you to the webinar on scaling full immunization in humanitarian settings. The zero-dose immunization program was established under Gavi's 5.0 strategy, as ZIP directly funds and partners with humanitarian organizations to deliver comprehensive immunization programming in communities where national immunization programs face barriers associated with insecurity, conflict, or crisis. When we look at the immunization programs, especially in recent years, we are increasingly seeing concentration of zero-dose children in areas with conflict, crisis, and in fragile environments, and may be cut off from government reach. These are some of the most difficult places to work or implement a classical immunization program. However, in order to reach unimmunized and zero-dose and under-immunized children, they often face multiple vulnerabilities. There may be limited health systems or no health systems or limited data, as we see often in humanitarian settings. This will require different ways of working, new models, new partnerships, and innovation. The work of the Gavi Partnership for Immunization in Humanitarian Settings is helping to unlock our understanding of these settings and highlights practical examples of what approaches would work and spotlight pivots that need to be made. The session today will include insights in delivery of full immunization and catch-up vaccination in children up to the age of 5 years in ultra-complex situations, and it will highlight the effective blending of immunization and humanitarian approaches. We have an excellent lineup of speakers today, and if we can go to the next slide, I will start with introducing Amy. Amy Ratcliffe is the acting head and senior technical lead for the ZIP program at Gavi. She joined the ZIP Gavi program in August 2022 and focused on establishing Gavi's accountability for learning and results across the ZIP portfolio. She is a trained demographer and epidemiologist. Amy describes herself as a global health expert who uses evidence and logic to improve return on investment for donors seeking to accelerate health impact and equity. We are joined today by Dr. Paul Kisia-Malalu. He is the immunization advisor and technical lead, the REACH program with the International Rescue Committee. Next slide. He is a public health professional, having worked in different capacities in various organizations. He currently serves, as I mentioned, with the IRC and REACH program. He has broad program management expertise in HIV care, treatment, reproductive, maternal, newborn health, child health, immunization, public supply chain systems, and he holds a Bachelor of Medicine and Surgery degree and a Master's in Public Health. We also have with us today Liban Ahmed Sharif. He is a project coordinator for REACH International Rescue Committee program in Somalia. Liban is a public health professional with extensive experience working across various organizations in diverse roles. He has worked with various organizations and currently is focused on reaching the zero-dose children in fragile and conflict-affected settings. Previously, he worked with World Vision, International Somalia, Save the Children, and has worked across immunization, malaria, and community therapeutic care. To close us out today, we have Lisa Hilney. Lisa Hilmy is the Executive Director of Core Group. Lisa has over 30 years of global health experience in over 20 countries, employing both human rights, gender, transformative, and community-based participatory approaches to addressing health disparities for women, children, and communities. She is also the chair of the WHO Civil Society Organization Commission and has leadership roles across a number of committees.
We've been on the ZIP journey for a little over 2 years, and the work has really evolved in some very important ways. One way that we'd like to share with you all is how we're using targets. And most of us are used to working in projects that, as grants, set targets for donor accountability and for program management. But what we've found is that some of the unique natures about the missed communities in which we're working with ZIP really challenge our notion of how we can set and use targets. And we want to talk a little bit about that today, some of the challenges that we've faced, and also how we're overcoming them. So next slide, please. I'll start by describing what it is about ZIP that makes it so fundamentally different than most immunization programs that we are familiar with. When Gavi set out to embark on ZIP, they set out to work, and the language that was used was beyond government, with an expectation that there are some missed communities that government programming cannot reach. And there are some clear examples of this. The government is either involved in or targeted with conflict. There may be a semi-autonomous or separatist area where the government cannot operate safely and effectively. There may be mass displacement or populations that are oppressed. What Gavi set out to do was the first set of regional awards with humanitarian partners. But at the early stages, they also thought this would simply mean asking humanitarians to work within the expanded program on immunization. And what we've learned is that this work is fundamentally different, and it requires us to work with both conflict-sensitive approaches, but it also requires us to work in ways, in places where we have much less access to baseline data and to data on populations than we've had in the traditional EPI approaches for microplanning. So if you'll take us to the next slide, please. ZIP's scope is different, not because it's the first immunization in humanitarian contexts. It's different because it's expected to be full vaccine programming in humanitarian contexts. It's meant to serve all of the children up to age 5 in missed communities with the full vaccine schedule, either for routine or catch-up schedules. It's also expected to fill any of the supply or demand side gaps that are left because the national program doesn't have full access to work in these communities. So again, ZIP is only appropriate where the Ministry of Health, national immunization programming, and EPI partners cannot work safely and effectively. These are places where the government is involved in a conflict or crisis, where semi-autonomous or separatist regions and local authorities are managing communities or controlling non-state actors, where there's mass displacements with volatility, or where populations are oppressed or targeted. And as I said previously, and I'll come back to this theme throughout, what we've learned is that the work is not simply EPI by humanitarians. There have been needs to request waivers for national policies so that we can immunize up to age 5. But there's also a need for neutrality and independence. In conflict and crisis, showing up, representing the government can be a dangerous way to approach a community. It puts the staff at risk, and it can also put the community at risk. So finding the right balance with a partnership with the government, but also a neutrality and independence that allows safe partnering, means that there are ways that we need to adapt this programming in order to get to the humanitarian safeguards and negotiated safe access. Let's go to the next slide, and I'll start talking a little bit more about the project itself rather than the principles on which and the scope on which it's been founded. So this shows you ZIP's scale. This is a set of historical partners, and thank you very much to World Vision for all the work that they did in the West African region in the early days, and the current partners with IRC, the Cameroon Baptist Convention Health Services, and Core Group. Important to note that the work that we're doing is not national. It's in specific and limited locations. So wherever we're talking about targets or numbers, we're always talking about those present within a community rather than at the national scale. Because again, as I said, ZIP is only appropriate in those places where the Ministry of Health cannot work. Let's go to the next slide. To date, from December 2022 to April 2025, ZIP has provided 1.7 million children with their first doses of vaccines. As I've mentioned previously, moving those children along the vaccine schedule is critical. And I note that 936,000 children have received their last vaccines from ZIP, meaning that they have completed the entire national routine or catch-up schedule. So when we're talking about last vaccines within ZIP, we're not simply looking at DPT3, we're looking all the way to the very last dose, either of measles, 1 or a booster, depending on what the schedule is. Let's go to the next slide. So I want to move us into what we've learned about using targets within ZIP. This year, ZIP will be targeting 1.2 million children. That is roughly half as infants, 0 to 1 year, and half as children, ages 1 to 5. Let's go to the next slide. We're using these targets to track progress towards 4 doses, which we call KPIs. And I know this is a little bit small, but what we want people to really understand from this is that we're looking at children, and we're translating those numbers to the first dose of Penta, the third dose of Penta, the first dose of measles, and the booster dose of measles, if that is on the schedule. And we're tracking on a monthly basis with these numbers reported to Gavi. And we're assessing our progress not just towards monthly estimates of what capacity should be, but also tracking toward annual targets. And this is in some ways different from what's been done in EPI programming traditionally. Let's go to the next slide. So a few things that we've learned, and this is where I'm going to spend a bit of time. The first is that when we set out to do this, we recognized that data was scarce. But we also know that setting targets is critical for us to plan, to get vaccines and resources, numbers of vaccinators, and also to assess our progress over time. There was a large delay at the beginning of the programming. Some of this was in our inception program, so it was built in. But it was a delay to say we shouldn't start until we know how many children there are. And we've learned that in these missed communities, where access is restricted, where they are left out of administrative data. In some cases, we are finding new communities with satellite data and identifying communities that have not been previously or not currently mapped on maps that we would be using. So we're not even just saying that there's poor data. We know that these communities are the most likely to be left out. What we have decided then is critical is to work on what the best data we can get, and looking to humanitarian partners to help us get that data has been a really important piece. Looking at satellite data to identify those communities and using the community's history of access to help us understand to what age do we expect to find zero-dose children. We also want to then use on-the-ground assessments to adjust both our vaccine forecasts and our programming targets. And we also want to accept that we may reach our targets faster than we think if those targets have underestimated need. And so we want to keep vaccinating even when we go beyond what we think the target had set for us. So the first lesson there is don't spend time deliberating over targets. Start vaccinating and revise as you go. Let's go to our second lesson. The second lesson is that progress to targets is not smooth. It's not going to be a constant flat line like we expect to see in many EPI programs. In EPI programs, we often expect to work to monthly targets based on births and babies coming of age for eligibility for vaccines. So we often use the targets once we use vaccine forecasting and we say, this is how many children and how many vaccines we need, we expect to reach about the same number of children every month. But in these missed communities, we have children up to age 5 who have not been vaccinated. And we know that reaching those children needs to be a priority. So we talk about push catch up within the ZIP programming and try to structure and plan our work so that we can reach as many zero-dose children as we can without evening or smoothing our targets across the year. We also know that the work in these communities can be disrupted very easily, both by climate, flooding, and crisis. When we are negotiating safe humanitarian access, we need to work to maximize the access that we have achieved and vaccinate as many children as possible. So our recommendations here are, we shouldn't assume that these targets will be flat. We need to take advantage of those access windows as much as we can to reach as many children as we can when appropriate. Let's go to my last slide. This is that we need to monitor our population numbers for change, or I should say our last learning. We need to monitor our population numbers for change. We know that in conflict and crisis, we can have rapid change and we can have a rapid deterioration of security that brings with it population displacement. Many of the communities that are served by ZIP have received many people coming in for safety, but we've also seen cases where entire communities have been evacuated where they've had risk or threats from non-state armed groups or other disruptions.
Indeed, the session I'm going to walk through is a build-up on what Emma shared. We'll be sharing more of the experiences, the learnings and perspectives from the REACH program. Also highlighting how we have used the targets and the target setting process to inform our programming. So on the next slide, this slide covers our REACH scale. You have already seen with an earlier slide that Amy shared where the REACH program is working. We initially started in the Horn of Africa, 4 countries, Ethiopia, Somalia, Sudan, and South Sudan. But towards the end of last year, we extended to Nigeria as well as Chad. So that just shows you the geographic scale. But within those countries, we are supporting close to 175 districts. That's quite a huge number, and they are distributed differently, with Ethiopia being one of our largest ZIP program areas. It has about 110 districts in total. We work in 24 regions or states, but importantly, the REACH program works through a consortium of partners. Some were international, others were local, basically leveraging the strength and the networks of these national partners to identify, reach full vaccination amongst the mixed communities in the locations you're working in. You also see the targets that you have set for the year 2025, 0 to 5 years of age, just showing us the kind of scale we seek to reach. And these targets have been generated through a robust process that entailed engagements, consultations with various stakeholders at the country level, discussions, the Ministry of Health or NIP, where that structure is, and also trying to see what's the total need, and out of that, how much can the ZIP program contribute to. So the target just represents our commitment, but we know the need for the mixed communities and unhomeless children is still significant out there. On the next slide, we'll be sharing through some of experiences around our scope within the REACH program. First of all, for us to reach full immunization within the locations we are working in, we realized from the target setting process that those communities were experiencing different barriers to service utilization. It was either safety, security, they were having conflicts, or the infrastructure was basically destroyed from years of war or looted as a result of conflict. We also had different non-state actors who are impeding utilization of services. But for us to successfully reach full immunization, for us to successfully vaccinate those children, we realized we had to provide a broad package of services so that we meet the needs of those children in those areas. On service delivery, we noted that humanitarian access was a constraint, and indeed we had to employ humanitarian negotiation strategies to allow us gain access in those communities by engaging the various state actors. And that way, we got a window of delivering the services. Thereafter, we had to predetermine what would be the best service strategies that will effectively allow us vaccinate those children. We employed various methodologies, including GIS for service optimization, which allowed us map the children, the mixed communities, the numbers, and their settlements. Through that, we are then able to plan the different sessions for service delivery. We also adopted different or differentiated service delivery modalities, having known the different characteristics of the communities. Some of them were mobile, others were living in cross-border settings, others were, pastoral communities or nomadic communities, others were IDPs and refugees. So we had to employ tailored strategies that will assist us meet the needs of those communities. For example, in areas that are having heavy presence of non-state actors, we had to employ quick in and quick out strategies. Some people used to call it hit and run, basically looking at windows of opportunity to vaccinate within a control area. Then you move in to vaccinate. Thereafter, you move out and, of course, plan follow-up sessions. The other area which the REACH project had to cover or focus on or support was on capacity strengthening. Now that these fragile and crisis settings have experienced many years of disruptions. We noted the frontline workforce was either unavailable or inadequate, or those people were there didn't have adequate skills. So as a project, in some of the settings, we had to recruit vaccinators, mobilizers, and even train them. For other areas where there were some rudimentary health workforce, we still had to retrain them, and also build their skills through mentorship and on-job training. On mention supply chain, again, in view of the context, supply chain systems were disrupted for long. As a program, our first task was to just look at the gaps. What are the existing gaps? Because some of the areas working in had minimal national immunization program reach. So basically, the communities were cut off from the national plans. They were cut off from the national API systems. So nothing around supply chain system was either existing or was minimally existing. So from those assessments, having identified the gaps, we then had to prioritize our investments. For some regions, of course, we relied on NIP where they're existing to access cold chain. For a few other regions, we had to procure the cold chain equipment, of course, supported distribution to ensure last mile reach. But recently, actually in the course of last year, we noted some areas could not be served by the conventional cold chain equipment. Those are areas that are cut off, hard to reach, bad terrain, they don't have electricity, they have no functioning facilities. We prioritize those for Indigo as a innovative last mile cold chain backpack. I'll talk a bit more about it in subsequent slide. On logistics, again, for us to deliver the services effectively, we needed to get access to vaccines. And this varied from one region to the other. As I mentioned earlier, some of the regions were having some semblance of an IP access, others were completely cut off. So for the regions that had NIP access, we had to negotiate with NIP to allow us have vaccines to vaccinate those children. And we ran into some problems. We realized that we are seeking to reach full immunization for the group 0 to 5 years, and yet the NIP was probably focusing on the cohort of 0 to 2, which was within the immunization policy guidelines. So this cohort of 2 to 5 years was not included in the country or the NIP plans. Yet that's where the ZIP was focusing on. That's where we saw the need of these unvaccinated children who required that antigen. So we negotiated for access those vaccines for those areas. Now, in the areas where there was completely no NIP, again, as I mentioned, we had to procure. Indeed, Rich brokered one of those historical negotiations where we had to engage with the support of Gavi, discussions with UNICEF to procure the vaccines and have them delivered to this region that was not being served by NIP. On the next slide, I'll talk about a few other areas that fell within our scope that required to focus on for us to fully vaccinate the children. I spoke about humanitarian access. This was central to our work. And this was one of the approaches that really distinguished the traditional EPI services, the traditional immunization services delivery, in contrast to what needs to be done to deliver immunization within the conflict, fragile, and crisis settings. Because there are some lancet actors who are found in these fragile and conflict settings. In some instances, they may act as the gatekeepers. So we needed to engage and negotiate them through the able support of one of our humanitarian advisors, who assisted us in putting in place a strategy or a mechanism through which we'll engage these lancet actors to effectively have some access to the communities. Demand creation. Yeah, the communities are facing various barriers. The children, the communities have experienced years of conflict. Most of them are living in fear. They were having limitations to reaching some facilities for immunization services. But there are also other supply side barriers. For example, healthcare workers in some of those areas have found vaccination of these children who are outside the immunization policy as a barrier because the policy was limiting and they were not used to it. So that was a major gap. And we had to, address it through engaging the decision makers, the policy makers, engaging the Ministry of Health where it exists, and also doing capacity building, training, and sensitization on the need to have the children vaccinated and ensure that they are receiving the full immunization. Data management, another area focused on, because the 0 to 5 years group was going beyond what the NIP EPI system was used to. So the tools are structured to capture data for the cohort that is served by the policy that was there. But for us to vaccinate, record, and report the children who are outside the policy, those who are 2 to 5 years, we had to modify the existing data systems. And this was through consultative process with the various stakeholders, including the NIP, where it's existing. Some of the changes included, having parallel register in Somalia through consultation. That's what was agreed on. In Ethiopia, we had to modify tools that will capture data for children who are more than 1 year, because the policy was capping up to 1 year. In South Sudan, we use the current tools, but we just made some modification on the summary tools, just showing you the variations from one country to another to enable us be able to collect this data, report, and share evidence of our impact on reducing the unmet need of immunization among the 0 to 5 years. Advocacy, of course, using the evidence we're generating, we made advocacy with the various stakeholders, especially the NIP where they existed, to allow us, for example, have access to vaccines, negotiate the advocacy for modification of the tools to allow us reporting of these children who are 2 to 5 years. On the next slide, I'll just try and talk through how we have used targeting to improve our programming. I may have touched on some of these things, but I'll just try and highlight a few areas that touch on my experience. In timing, scale, and reach, through the target setting process, we were able to analyze the need for immunization within the group of 0 to 5 years across the different regions. And from that, we identified the areas that were having the greatest need, either by cohort, and the cohorts we mean, the infants, you have the group of 1 to 2 years, and also the 2 to 5 years. We also able to look at the unique characteristics of the different populations. So that in itself assisted us scope our scale, narrowing down to the priority focus areas that we could work in, and also the actual numbers that we are seeking to reach as a program. The other area I've used, targets is really in terms of forecasting and resource mapping through the targets that we set. Of course, consultatively with the various stakeholders, we use those numbers to estimate the vaccine requirements, estimate the cold chain requirements, also estimate the human resource requirements. Of course, having scoped those resource requirements, we either used internally the program resources to address some of the needs, like around human resource, or for vaccines, we negotiate with the ministry, as I earlier mentioned, including cold chain. For other areas, we had to procure, of course, to allow, and we had to procure as a program to ensure that those areas not served by NIP have this required resources. The focus team also informing our first programming, and I'll talk a little bit more on this on the next slide. Yes, strategic planning. The targets have really assisted us in developing, service strategies, all the way from delivery modalities to session planning to, even adjusting those strategies. By knowing the different population segments, we had to develop or formulate a strategy that will serve them, a strategy that will meet the needs of those communities. We also realized that some strategies could not work in some settings. We also learned that the traditional EPI strategies will not effectively work in some areas. So in a country like Ethiopia, from the target setting process, in Tigray, for example, they realized that some of them were in the IDP camps, refugee camps, others were in the community. But now the numbers that were set were not reliable. So the team had to organize for head counting, going to the community, estimate the number of children who were there. And after knowing those numbers, they then came back and decided, our strategy will be door to door and extended outreach, because that's what will meet the needs of the children in those areas. Another example is around, session planning. For areas that are, controlled by non-state actors, you may not frequently go there. It requires negotiation to be allowed to go and vaccinate. When there's some tranquility, then you come out. Then, of course, plan the next session when you have another window to negotiate and go into vaccinate. So there are those variations. And of course, all these things are building on the target that we had already identified, including their unique characteristics. The other area which we have used target setting is just in performance management. We use the targets to track our progress against the KPIs. We're using data analysis at subnation level to improve our performance through the course correction plan development. We're also using the targets to just drive our accountability to ourselves and the communities, and also inform advocacy. And I'll give an example. From one of the analyses in South Sudan, we realized that when you look at an overall country level performance, the picture may not be so badly off. You may realize that you are doing well on the 4 KPIs. But as you analyze at the subnational level, you get the subnational differences, the subnational variations. Some locations not doing well on some cohorts, others not doing well on another cohort. A good example being that, for infants, you realize not doing well across for various reasons. But in other locations, they are generally doing well on all the cohorts. So through these analyses, we're able to identify course corrective measures that will ensure our strategies are reaching the children that we want to serve with full immunization. The next slide is on just our experience on tracking. And in Ethiopia, for example, we have annual targets, annual commitments that we are all working towards. And through one of the analysis, I gave the example of South Sudan, but for Ethiopia, through the analysis, you realize that nationally they are doing well. They're doing well on all the 4 KPIs, but then look at the the subnational regional level analysis, you see variations. For example, Tigray, as at end of March, they were surpassing the target, the expected level of performance, about 25%. But Oromia, it was about 27%, slightly above. But Amhara was also about 26%. But then when you go to the subnational level, you realize there are those variations. And just as I shared for South Sudan, the teams have actually developed improvement plans to ensure that you're all working towards reaching the children. The last slide I'll talk about is on Indigo, just sharing some of our experiences. Indeed, as I've shared earlier, Indigo has come up as a game changer. There are regions where the traditional cold chain equipment will not work. There's no electricity, refrigerator will not work. You don't have the vaccine carriers. But now Indigo is one of those innovative technologies that we have adapted, currently rolled out in one of the regions, fully being utilized. And of course, a number of other deployments already lined up with procurement already completed. Now, this Indigo is a great device. It's able to store and maintain the required, recommended cold chain conditions for vaccines for a period of 5 years. So the teams are able to, go out there for those mobile sessions. They're able to vaccinate the children for the 5 days, then come back over the weekend, for example, to recharge that Indigo. It's quite a departure from our traditional vaccine carriers and the other cold chain equipment. We'll be deploying more in the other areas. I think that's my last slide. I'm sure Liban, as he comes in, he will talk more about the other country level experiences. Thank you so much for listening to me.
Thanks, Olake. I think I'm Liban Ahmed. I'm the project coordinator for Somalia Reach. I may be taking you some of the experiences we have gained within the country, Reach, Somalia, how we have done, maybe the context that we would like to share with you in terms of the experiences we have gained so far for the last, starting maybe from 2022 to date. So maybe you can turn next slide, please. Yeah, I think just to give you a highlight of where we do business within Somalia is, South is a state. Southwest state, which we are implementing in Southwest state, one of the highly populated states within Somalia. And it's divided into 3 sub-regions, namely by Bakol, Lower Shabelle. And we know that we are focusing on 12 locations out of the 18 districts that we have under the Southwest state, mainly due to the highly needy, children that are said to be in need of this ZIP programming. So I think we are working closely with 4 local partners. We are working with Grado, we are working with Riado, Ayub, and Shakdo, who are all operating within the sub-regions that we identified. And for us not to leave this project to be standalone, we focus mainly on integrating projects, especially immunization when it comes, for us to increase the demand and utilization properly within the support of the community members that we know within Somalia. They are more or less, the preference rate is, when you integrate immunization with services that are already leveraging, so that the buy-in process can be high. Next, please. Yeah, as of the next slide, this gives you how we have done so far within the country, starting from December 22 till April 2025. As far as the impact is concerned, we have had 270,000 children that were given first vaccine doses, and starting from 0 to 5 years of age. And as of 2025 target, we are targeting 144,607 children. And among them, we have 76,589 infants, whereas the rest seems to be older children, 1 year and above, till 5 years of age, who will be receiving the first dose from ZIP in 2025. Next, please. And I think if you look at the next slide, we have seen majorly, I think my other colleagues like Dr. Paul has emphasized on these different points that were highlighted in the slide. However, I will be touching few like humanitarian access. You remember? Hello? Yeah, and as far as humanitarian access is concerned, in this project when we were starting, we really had challenge in terms of accessing. I remember this project has been dealing with beyond the government control areas where we had, partially and hard to reach locations. So we have to work closely with humanitarian aid. We have to work with key influential community leaders that can ensure us penetrate some of the armed control areas for us to, take such immunization service to such very complicated area has been a very challenging environment, but we have to look and ensure that we use all the strategies that are applicable to such environment, like we have hit and run for some context, and we also have, quick in, quick out for certain strategies that we can manipulate and ensure that the needy children are reached in that manner. And looking at demand creation and community engagement, I remember we really had issues in terms of, and the barriers that we have observed within this country. The community were totally believing in might-related behaviors that immunization could cause, potency for their kids, and with that, they were not considering immunization to be one of the top priority for their children. Hence, we have to do a lot of, studies pertaining gender, empowerment, diversification and inclusion, where we have seen decision making in terms of, mothers designing to take control of their children to take to immunization service area has not been positive or feasible at the initial stage. However, after doing the studies with the support of ThinkPlace and maybe other global partners, we were able to come up, with what are the enablers and the barriers that are behind these scenarios. So we were able to come up with different ideas like mother to mother and father to father dialogue session, where we need to have all those information that we need to disseminate towards the community, and we also lessen, barriers related with demand creation. We also establish what we call immunization, sessions at different vaccine outreach teams, so that the community are aware of what is happening and what will be done for their kids. And in that manner, I think we have lessened the barriers that we have been seeing. When it comes to data management, it's an area where we have also seen some gaps, especially when we were starting the project. I remember the MOH, telling us where are you recording zero dose, or maybe a catch-up strategy that's maybe 1 to 5 years, when the government had only planned for routine immunization 0 to 11 months. So with that, we were able to do some engagement with the MOH, sit with them, try to convince them that this is a new setup, that we will need to reach, those children that were said to be missed communities in fragile context. And as a result, they advise us to, put in a separate register, so that finally we'll come to a common understanding of how we need to capture the data towards the DHIS tool imposed by the government. And as well, not forgetting, we are also reporting ComCare through rich data that will enable us to track properly how the data flow will be done at the facility, at the outreach level, TLC to reach the district, the national, and then at the higher level, finally at the PMU and the donor. And as far as the advocacy is concerned, this is an area where we have really had issue with the MOH when we were starting this project. Remember, the MOH, the government only had that immunization, routine immunization policy that they have already established, and everyone needs to be, going along the immunization policy that the government have already shared. So for us, what we brought was a catch-up strategy for all the children beyond 1 to 5 years of age, and that needs now a policy that needs to be formulated from the government. So we have had engagement with the MOH in different scenarios where we have had, gaps from, especially sometimes, the MOH were asking for what kind of schedule do you need, or maybe do you have in place for you to do such business like maybe. And finally, we came to in a common understanding where today we have at least a draft from the MOH that was shared in the last 2024, talking about, how we need to do business as far as catch-up is concerned, catch-up for immunization children, immunizing children at older, more than 1 year of age. So that advocacy has given the government to at least pave the way for us to run till 5 years of age today. Next, please. Yeah, I think Paul has talked about more on these how we need to using targets for programming in Somalia when it comes to vaccine coaching and resource forecasting. We do target, then we bring the target for the estimated number of children towards the government, especially the MOH. They validate, then after validating is the time now we start, forecasting for cold chain and other vaccine related aspects, so that we are aligned with the government, will also agree with us. And pertaining the target health priorities, I think we were looking at, we know that out of the 12 locations we have selected, again, due to the need and the geographical location that you can cover, you may prioritize which areas needs, or holds more population, especially by Doha. We have selected as one of the highly densely populated area that we have targeted, so that we can start, rapid campaigns to vaccinate the newly arriving IDPs and the most needy children. When it comes to needy, direct attention, underperforming areas, this is an area where we have been, looking at the data that we have at the KPI for the sub-national performances. Is an area we analyze based on which areas or which locations are performing well, which areas or which locations have not performed well. A good example is the way you can see we have selected certain locations where we see to it that we need to bring strategies like push catch-up vaccination campaigns, where we need to initiate in that way so that we can reach the target before the project closes. And at cutting the edge, maybe cold chain technology, I think we have, the project has procured indigo cold chain equipment that will pave the way for the last mile delivery, where we see to it that where we have had gaps in terms of last mile delivery. Indigo requires like 24/7 power supply, and mapping has to be done in a proper manner. So that is something that we have done within the project, and we have shared with the MOH. We also have their approval, and this is something that we are in the process of installing and maybe capacity building the staff, the front line. Next, please. Yeah, as far as I think the immunization policy within the country is concerned, as I shared earlier, the first, you can see the first upper row is what you can see, the national policy immunization for within the country. That starts from routine 0 to 11 months till 15 months of age, where we have all the antigens, as you can see. And as far as zip or maybe the catch-up is concerned, you can see the lower rows where you have catch-up that will start from the age of 1 year till 5 years of age in that interval of 4 months each level. So I think yeah, next please. And if you look at these graphs, you can see all the antigens we're providing within the country. And you may ask why we have highlighted 4 bars or maybe 4 graphs. It's as a result of, us tracking these 4 KPIs within the rich KPIs that we track. So we are tracking actually DPT1 against DPT3, as others have already mentioned, and MCV1 against MCV2, sorry. Next, please. Yeah, I think we have a very nice success story to share with you from one of the remote areas within Baidoa State. Here, these locations have never been reached with immunization earlier, and as a result of support from geospatial data that we have been provided with the support of FlowMinder earlier, we were able to map out this location to be one of the strategic areas for us to at least ensure that they receive vaccination for their kids, since we have, roll out this area to be not receiving any immunization. Remember, within this state, we have had more mortality-related cases as a result of measles, diphtheria, and polio. So we have identified Nasib location to be one of the areas where we have seen they have not had anything to do with, immunization service, be it relating with either. We have, gaps like insecurity. We have threats like non-armed state group factors as a result of maybe issues related with logistical challenge. So we have mapped that location for us to flag as a high priority area, and then using one of our local partners, Riyadh, we were able to do to map out the activity, implement immunization services, and then we have local community health workers as well as women who have been playing a very great role in moving from house to house, doing mobilization, encouraging others to come and immunize their children. And as a result, we were able to see finally at the end of the sessions that 652 zero-dose children were receiving their first vaccine doses. 511 were able to complete their full vaccination schedule. And as a result, finally, we were able to see how the community were not hesitant in, expressing their hesitance in ensuring that they need immunization to be part of their daily lives, rather than believing that those mice-related behaviors. So I think we have seen a good progress in this village, and today, thank God that most of the children were vaccinated in this location. Next, please. Yeah, I think we are done from our end. Yeah, thank you. Over to you, Fulaki.
Liban, thank you for such an extraordinary presentation describing the situation and the approach in Somalia. Thank you so much. We are going to take questions from the audience and participants right now. We have invited you and welcome you to put your questions in the Q&A box at the bottom of your screen. So I'll be looking out for your questions. But meanwhile, may I invite Liban, Paul, Amy to be on screen, on camera, while I put forward the first question that we have. So this first question goes to Ahmed and Paul, Liban and Paul. And so the question is, what are the main challenges in reaching the same child multiple times in a conflict setting or fragile setting, and how did you overcome them to ensure full vaccination, especially those who are outside of specific internally displaced camps? So if you can share your experience on that, Liban, I think from the Somalia experience, and Paul, just across the board, and Amy, feel free to weigh in as well if you would like. Paul or Liban, who would like to start?
Maybe Paul can start, then I can come later. Thank you.
Okay.
Yeah, thank you so much, Dr. Falake, for that question. Indeed, as you have seen on the vaccine schedule, the children will require to come for multiple sessions for them to complete the full schedule. Some of the challenges that we have seen across include the mothers and the communities fearing for their safety and security because they probably had one window to come for the first scheduled antigens. Now, when they are due for the second scheduled antigens after 4 weeks, you find the safety is not permitting. There's a new conflict. So that has been one of the major barriers. Number two is the distance. These mixed communities live in areas that are largely geographically vast, poor terrain, bad roads, heavily flooded rivers, etc. And that limits, the ability of these mothers to come to bring their children for vaccination. So they may come for the first scheduled antigen, but miss the other one. The other one, which I've had, which is quite interesting, is the pain. We have had this in some of the regions. Children, when they get multiple antigens, multiple injections, they fear the pain, and that in itself has contributed to mothers, hesitating to take their children back for vaccination. I mentioned this because it's a unique one, which you have seen in some of the areas. The other one is about session disruption. Your planned for a session, the mothers came, they got the first jab of antigens. Now the second session is probably disrupted or canceled for different reasons. That discourages the mothers. Now, some of the strategies that have been employed to address this quickly. Number one is closely planning the sessions to the community so that they are involved. They are aware that immunization is important for the children, even if they're outside the policy. But importantly, can we be flexible enough that if we miss one session for different reasons, they need to be flexible to come for the next session. The other one is just demand creation or the importance of vaccination among these children. If mothers understand the importance of that vaccination, they will be encouraged to bring them. The third one is taking the services close to the communities where the children are. Doing more of mobiles, doing more of outreaches, doing more of hit and runs, using the windows of opportunity for vaccination. And the last one is just about, staggering the injections. That's something which is being considered in view of the pain so that the mother is comfortable to have one jab, then bring the child for the next jab. But of course, that's dependent on the logistical elements around the travel of the mother to the point of vaccination. Those are my few points. Maybe Liban can add on that. Yeah, thank you.
Thanks, Dr. Paul. I think you summarized whatever I wanted to say. You have really mapped it well. So I think I don't have any extra idea to, maybe because of time, let's
Okay.
give others here. Thanks.
Afalake, just one more. Continuous negotiated access will be the other solution. Thank you.
Thank you very much. I'm going to move us on because we have a flood of questions coming in, and I want to take the next question from Danielle. So Danielle is asking, did you face ministry resistance in opening the targets from 24 months to 5 years? And what were some of the strategies for advocacy that you utilized? So if you can speak to that, that will be very, very helpful.
Falake, could I start on that one and
Yes,
then
please.
hand it over to Paul?
Perfect.
So one of the things that we noticed really clearly was that policy restrictions were one of the most systemic and intractable kind of challenges that we had to the program, right? They were across the entire program because every country manages its vaccine supply and prioritizes infants. ZIP started before the big catch-up was started. And so one of the early struggles that we had was making sure that there was a acceptance of the need to be able to vaccinate older children. As we've worked, this is an area that we have really worked with Gavi and the country teams in partnership, so that we have looked to identify both the policies that are on the books and the ability of the country to prioritize who they give vaccines to, right? But to help them understand that the opportunity that is within ZIP and the nature of these ZIP communities really deserves this special attention, either with waivers or with inclusion within the big catch-up policies and guidelines that have come out. So this has eased over time as we have catch-up schedules, as we have catch-up guidelines, as we have catch-up, all the way down to training for the vaccinators. But we've still needed to make sure that this is applicable and welcome in the communities that ZIP is working in. So we've even had cases where ZIP communities were given second tier because they were first priorities before the big catch-up. They weren't then and included as priority for a catch-up. So Gavi's role working with the country teams has been very critical. Another thing that IRC has done is developed an advocacy kind of toolkit for their countries to be using to make sure that they're advocating for their communities and for the access inclusion up to these older ages that will last even beyond the big catch-up. So these cohorts and the eligibility that extends to these cohorts should be retained after the big catch-up, and we're working there to try to preserve that. I don't know if you may want to go to other questions, or you may want to throw it to Paul. I'll let you, Falake, decide.
Yeah, thanks so much for that, Amy. I think you raised such a critical point that when you look at it holistically, the work around ZIP and reaching children up to the age of 5 and the big catch-up should be a seamless, holistic policy that is able to be incorporated into national immunization programs. And I think from what I hear, we are certainly moving in that direction. Paul, did you want to add anything? Otherwise, I have 3 other questions for you. Paul?
I think Amy ably covered, and I'll say the experiences varied from one country to another. In one country, policy was a major issue. In other countries, they'll tell us, yeah, you can vaccinate, but where are the vaccines? Where are the cold chain? In other countries, they told us, we have enough vaccines, you just come vaccinate and give us the number. So the experiences varied from one country to another. Resistance was there, but through advocacy, strong advocacy with support from Gavi, and IRC, the local partners, it made it possible to navigate some of those challenges. Thanks.
Thank you so much, Paul. So I have another question sitting here, and this is referring to the approach you mentioned, such as the mother-to-mother groups and the community engagement sessions. And so the question is, really looking at how do you sustain the mothers groups in these fragile and highly mobile environments. So if you want to speak to that, Paul, I think that is also coming to you.
Yeah, I would have loved Liban to speak to it. But what's important is that, winning the buy-in of the community and the mothers is critical to sustainability of this program or any other program. And we know the mother-to-mother support groups are voluntary. It requires a lot of personal level commitment for the people you are targeted to come forth. So what has been done, and I'll give the example of Somalia, is involving the mothers in designing the interventions around community engagement. Involving that community was critical. It made these members of the community who are coming for those, I would say, community sessions, feel like they are learning something, feel like they are gaining. And when they see value in this kind of engagement, they will always hold, because they realize from this engagement, from these community sessions, they learn, they're able to encourage each other. They're able to realize that despite the many challenges they are facing, accessing immunization is still possible, and that the children, once vaccinated, they will be healthier. And once a mother is convinced that the baby is going to be happy and grow healthy, they get motivated. So I'll feel those are the key things. We didn't use monetary or other incentives. That cohesiveness was built from winning community trust here.
Thank you. So let me ask Liban, do you want to add anything to that?
Actually, Paul has covered. He kept well how he talked about issues to do with mother to mother. As far as this country, Somalia, is concerned, we have known that the voice of mothers initially, as I talked about earlier, wasn't heard, and it was like they were not considered to be high level. So today, when we have established these mother to mother and father to father sessions, we have given a portion to the mothers within themselves to discuss internally, disseminate information with their friends, their loved ones. And that has really paved the way for them to understand more and gain more. It has now changed gradually from how they were initially to how they are today. And that's why we see the difference. Today, as I shared that story of Nasib village, where women standing, and advocating for others to bring their children for immunization, which is a very good case that we haven't seen earlier in Somalia. So I think with that, you can understand, and with the support of that study that we did, Jeddah, it has really paved the way for so many things that we haven't seen within this country, really. And today, mothers can stand in front of you without fear, and she can say immunization is the best for my kids and your kids. Let's please immunize. And we have minimized even number of diseases as a result. So thank you so much. That's what I will add here. Over.
Liban, you added such an excellent component to that. Thank you for bringing that practicality. One more question for you, Liban, and this is really looking at the supply of vaccines, understanding that this is still a key issue. And so how can we ensure that the supply forecast is well estimated, besides just advocacy for the correct target estimation? And how do you ensure that that coordination with the Ministry of Health is effective in terms of access to the vaccine supply that is needed? Can you speak to that, Liban?
Yeah, thanks, Foleke. I think when we were starting, I think we had that gap, and it really, gave us an understanding of how do we need to do our forecasting. So whatever we do forecasting is on quarterly basis. We have cold chain hubs at the 3 sub-regions. Then within that cold chain hub, it's manipulated or maybe managed by the MOH. And then in collaboration with supporting agencies like UNICEF with local partners. But for us, one thing we are sure is, when we do forecasting, of course, we do forecasting based on the target estimate that we have done. Remember, This is a country that has not done a population census wisely for quite a number of years. And what we do is only depending on estimates. So depending on that estimate and the kind of micro plan that you have is what we focus on our estimates. So the 3-month estimates that you do then is what you share with the MOH. Of course, they do forecasting with the federal government. Then reports are shared on a monthly basis, what we have achieved. Now, with that report that you bring forth, is now the time you can go for the next forecasting for the next quarter. So that is how we do business within our sector. Yeah, thank you.
Falake, if I can just, I know that we're close to wrapping up, but if there's just one quick thing I can add is that we've also
Good.
found how critical Gavi's role in helping get access to vaccines is. So in many cases, the missed communities that we're asking the grantees to work in are not the missed communities that have been prioritized. They wouldn't be missed communities if they'd been previously prioritized by government. Gavi does quite a bit of work every year with the grantees to make sure that there will not be any disruptions to the national supply at national level. And that allows us to be able to advocate and assure access that then can flow down, as Liban's saying, to the regional allocation of resources. So again, we found that this partnership between Gavi and working at all levels of the government to make sure that we're getting this, administrative levels of the health system, that we're working to make sure that we're getting this access. So I think if we're at time, but I wanted to really just say this partnership of reach is really unique because it's not just that the grantees are working on the ground. We're really thinking all the way from the alliance down and making sure that we're identifying those hurdles and barriers. And this is something we'll be talking about on future webinars.
What an exciting discussion today, but we have to wrap up now. Just 2 quick takeaways from me. Really tailoring to local levels with flexibility to adapt and rapidly changing situations. Continuously monitor and revise approach. Engaging the affected communities and using the human-centered designs, using the innovations. You've talked about several of them, the satellite imagery, the cold chain vaccine carriers, and of course the ComCare and ODKs, and using different service models depending on the situation to ensure both full vaccination and catch-up and being very close to the communities through different methods, quick in, quick out, hub and spoke, integrated approaches. And just lastly to say, full immunization beyond campaigns is possible and can be scaled. I'm going to close out and hand to Lisa. But before I do, I want to give a call to action for everyone that is on this call. Please spread the word, spread the message. We are at a critical time and we really looking at the support around Gavi's replenishment. And we know that the global health and humanitarian landscapes are a key priority. Continue to stay tuned and watch this space as Gavi calibrates resources, but also ensure that there's a collective shift in expectations for greater vaccination equity for missed communities. So let's make sure we can look beyond what we have and bring in the innovation for more equitable immunization. Lisa, over to you.
Thank you, Faleke. Excellent, excellent words. And we know today is just a huge day for Gavi and the replenishment. So I'd like to thank all of you for joining us today on behalf of Core Group. We really appreciate your time, your attention, but also the lessons you're going to take forward. And I look at our colleague Cynthia in the chat who said, these lessons I can take home to Burma and because of the conflict there. So that's what this is about. Our speakers and our moderator, Dr. Faleke Olayinka, Amy Radcliffe from Gavi, Paul Malalu, and Libel Sharif, thank you very much for your expertise. This program and what it's hoping to achieve and what you've achieved already is critical, especially in today's environment with so many humanitarian situations and areas that are difficult to reach. I think a lot's been said, the community engagement piece, humanitarian access, and some of the unique things that will be implemented, indigo devices for the cold chain, the use of ComCare, and reaching 1.2 million children. I think this is going to be amazing. Next webinar, stay tuned and look for more on social media, on the core group, and everyone that register will get the updates and the recording. The next webinar will focus on the barriers to full immunization in humanitarian context and the practical strategies to help improve that access and equity. And so please look forward to this series. These important learnings are just really great to take home and to implement in your programs and adapt. Make sure you're connected, and we will be sharing that video. And once again, thank you all for being with us today. And we wish you the best in your work, and we look forward to continuing the conversation. Thank you all for all the great work.